Hi, this is Brian Kim. I'm going to share with you case number 64 in the best way to do cataract surgery series. This is a dense white cataract. I'm going to use Trypan blue. And you're going to see systematic lens disassembly, double chop, cross chop, and in doing so, using minimal ultrasonic energy to disassemble this lens. So first things first, I like really good draping when I do my cases, so I trim off any lashes that might be in the field. I'm using a cotton tip to steady the eye and then a corneal marker to help me center and size my rhexis. I'm making a paracentesis incision on the right side and then on the left side, making sure my incision is flat to the iris plane, which will create a nice corneal shelf, which will allow me to achieve a self-sealing corneal incision. I'm injecting some intracameral lidocaine and then some intracameral air. And then I'm going to inject some Trypan blue. The tip was a little bit clogged. That's why you saw it kind of shoot out. So I'm going to paint the surface of the anterior capsule with the Trypan. And then I'm going in with the dispersive viscoelastic cannula and pushing the dye as well as the bubble out. Once the anterior chamber is filled, I'm going to do my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, turn the eye towards me with the cannula, and then enter. I injected some more viscoelastic, and then I went with the forceps to puncture the central capsule. I'm grabbing the right side of the tear and starting to go around circumferentially. I started injecting a little bit of more viscoelastic after I made my incision. By doing so, I feel like I have a little bit extra control of my rhexis by injecting that little extra dollop of viscoelastic. So that's, again, something I'm doing more recently. That's just a little bit of a tip to flatten that anterior capsule by increasing the viscoelastic pressure. This is the capsular fornix hydrodissection technique. I place the cannula out underneath the rhexis edge on the contra-incisional side, point the tip down, get a nice fluid wave. I start rotating the lens with the tip down on the right side, spinning the lens nicely. I tried to hydrodelineate, but you can see the lens is fairly dense, so I didn't really do anything more with that. I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, remove the surface epinuclear material, place the chopper out underneath the rhexis edge contra-incisionally, place the phaco tip vertically sub-incisionally, bringing both instruments together and crushing the lens in half. That's a double chop, placing the chopper around the right heminucleus, pulling it centrally, crushing it and dividing the right heminucleus, that is the cross chop. I'm going after the first quadrant, pulling it up with a little bit of vacuum, getting the chopper around it and crushing it with mechanical fracturing forces, crushing it into smaller pieces, and then emulsifying the lens pieces. You can see as I did the chop maneuver, the phaco tip actually caught a little bit of the edge of the rhexis and created a little bit of a semicircular defect in the capsule subincisionally. Thankfully, it didn't radialize. This is the second time I've done that, and I think I've recorded a case before doing that. And luckily, this has happened twice and did not cause a problem. But this has to do with being a little bit too aggressive and going out a little bit more peripheral than I should have with the chopper when I turned it vertically. I should have stayed a little bit within the capsulorhexis edge when I did that maneuver. Again, I think I was a little overzealous because I knew it was a big lens and I wanted to really get that phaco tip vertical and as peripheral as possible. But for the future, I just have to be more mindful in these dense lenses not to go so peripheral with the phaco tip when I'm rotating it vertically for the double chop maneuver. You can see I've broken down that second quadrant as well. There's a little remnant of that second quadrant that I pulled up, and then I start emulsifying that last piece. Rotating the second heminucleus in front of me, place the chopper around the lens, pulling it centrally towards the fingertip, which is positioned deep in the bag, crushing the lens in half, and then separating the two pieces, placing the chopper around one of those quadrants, pulling it centrally towards the fingertip, and dividing that quadrant. Again, because I'm using mechanical fracturing techniques without fluidics, I can do this very carefully, very safely, not worrying about the vacuum snagging something it shouldn't, such as the posterior capsule. Using mechanical fracturing forces to sandwich and crush and divide the lens into smaller pieces, and once they're small enough, I start to emulsify the lens pieces. But this lens is quite dense. It's not a white, soft lens. It's got some density to it. So I'm really being mindful of crushing the lens pieces into smaller pieces because I really like to minimize ultrasonic energy when I do cataract surgery. I do feel like by minimizing ultrasonic energy, I feel like it gives me a lot more control. I feel like I've had less complications with cataract surgery since switching to this technique. And also, I do have clearer corneas postoperatively, even as early as post-op day 0 or day 1. So I place the chopper around the last quadrant, pulling it centrally toward the fingertip, crushing and dividing the lens piece. You can see some adhesions there. Again, I'm just positioning the lens pieces and then crushing it between the chopper and fingertip, and then emulsifying the lens pieces. You can be very patient and careful with this technique. Again, because the maneuvers are performed under irrigation only, you don't have to worry about causing a problem. You can very carefully just mechanically position the lens such a way that it's going to be sandwiched between the chopper and the fingertip, crushing it and dividing it, and then use ultrasonic energy and vacuum to remove the lens pieces. So this is a final piece. It has some density, so I'm being very careful not to use aggressive vacuum or ultrasonic energy because this bag is completely wide open. There's no epinucleus. There's not even much cortex as well in this dense white cataract. So I'm mechanically crushing the lens pieces into smaller pieces, and then when I press the pedal to emulsify the lens piece, I have the chopper deep to protect the posterior capsule. There's a little piece stuck to the cornea, which I guess is a good thing. It does tell me that I have still quite a bit of viscoelastic coating the cornea, but I want to get this little piece. And what I did here is I decompressed the eye by turning off continuous irrigation. And when I did that, it caused the lens to come towards the wound. Since the wound is open, the fluid came out of the wound and it caused that piece to come towards the wound. So that was a little bit of a trick by just turning off irrigation, letting the eye collapse. So I take the chopper out, push BSS in, take the phaco tip out, and go in with the eye in a handpiece. I start to polish underneath the rhexis edge, but again, because this is a fairly clean bag, I don't see much cortex at all. As you can see, as I was in the cortex mode, as I was sweeping around, I actually snagged the anterior capsule and also stretched the zonules down and to the left of me. So I quickly switched to the polish mode because the polish mode is just a lot more gentle as far as aspiration and vacuum, and I started sweeping underneath the rhexis edge. This was really a very clean bag. So I switched to the BSS cannula, pulsing the subincisional space, and lo and behold, I see a bunch of lens material start flying out with the cannula. So that subincisional cortical flush or capsule flush technique really works well to remove that subincisional hidden lens material. So I'm injecting some cohesive viscoelastic to fill the bag, and I start to polish under the rhexis edge with the sweep. Again, you see that scalloped edge in the subincisional anterior capsulorhexis edge, and so that was when I snagged it with my phaco tip as I turned it vertically to perform the double chop maneuver. And as always, with very dense lenses, I do think they have zonulopathy, which was seen in this case. So I like to widen the incision and go with a 3-piece intraocular lens. I'm going to go in with the barrel pointed to the left, which injects the leading haptic in a planar configuration. It goes within the bag very nicely, and then the optic comes out flat as I rotate the barrel 9 degrees counterclockwise. I use a Maltzman to dial in the trailing haptic within the bag. I go in with irrigation off, place the INA handpiece underneath the lens, tilting it up, removing the viscoelastic from within the bag. And I'm just dilating the haptic, removing all the viscoelastic from underneath the rhexis edge here, and rotating the lens here just to make sure it centers nicely. I'm just spending a little bit of extra time here rotating the lens. Sometimes with these stiff haptics, you have to rotate the lens in order to get it to center well. And so I switched to the visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a dense lens, white lens. I performed double chop, cross chop, mechanical fracturing. You could see as I turned the phaco tip vertically for the double chop maneuver, I actually caught the edge of the rhexis, which created a scallop defect. Thankfully, this is only the second time I've done that, and both of the times I did that with very dense lenses, and it didn't cause any complication other than creating a small little defect. But it does go to show how aggressive I am with tilting the phaco tip vertically for the double chop maneuver, and how I'm actually doing bidirectional crushing forces to divide the lens. So again, this is a very dense lens. You can see the CDE was minimal. This patient had a very clear cornea postoperatively. I performed double chop, cross chop to mechanically fracture and crush the lens pieces. By using those forces to crush the lens, I'm using less ultrasonic energy, which I feel is safer. I have much more control when I'm using my own hands to crush the lens piece between the chopper and the phaco tip, rather than depending upon ultrasonic energy, which can be risky in some cases when utilized improperly. Thankfully, this patient did quite well despite causing a little bit of a scallop defect in the subincisional anterior capsulorhexis. So I hope this was helpful to you, and I thank you for your attention.